is a more subtle case courtesy of Dr. Margoum that we saw earlier today. So subtle pink lesion, there's many little pink lesions here. So you may be thinking this is an inflammatory dermatosis, maybe seborrheic dermatitis, Grover's disease. This particular lesion, maybe it's actinic keratosis, squamous cell carcinoma, it could be many different things. Let's take a look at the dermoscopy. So it's very specific. Dotted vessels, thin serpentine vessels. We'll highlight that there. Invasive melanoma, 0.6 millimeters. Lesion on the back, clinically quite subtle in appearance. Dermoscopy, again, the same pattern. Dotted vessels, linear irregular vessels. I'll highlight that again, 0.75 millimeters. Lesion on the back of the arm, quite broad, with a central area that's a little bit darker. So the central vessels may play out. This is an example where it holds true. So you see the whole lesion here, but the central part gives you the most information. Dotted vessels, linear irregular vessels, 0.55 millimeters. Lesion on the leg, clinically very subtle. This could be many different things, but for me, I would probably have predicted squamous cell carcinoma just based on this appearance. Dermoscopy, it's slightly different. You don't really see the polymorphous vascular pattern. It's really just dotted vessels. So many dotted vessels, but there's some variability in the size and the shape. They're not all quite the same exact appearance. The clinically, right, there's even a little bit of scale. So scale, sometimes you see in these amelanotic melanomas, not as pronounced as in squamous cell carcinoma. All right. So are all amelanotic melanomas, do they all lack pigment from inception, or do they lose pigment over time? It's an unanswered question. But I'll show two examples really that support either hypothesis. So I think both are probably true. This is an example that actually was monitored over time. So this is 3 months between this picture and this picture. And you can see here, there's more pigmentation than here. And we'll look at dermoscopy. So here you don't see too many vessels. You see some irregular pigmentation. 3 months later, what you see, many more dotted vessels. An example of melanoma in situ. So an example where a pigmented lesion becomes more amelanotic over time. This is another example from my clinic. This is a patient who's had multiple primary melanomas that I use total body photography with. She has many very light nevi. Many of them are pink in appearance, light tan. She's probably an MC1R variant, as we heard about earlier today. So this is the baseline lesion, a very small pink lesion. Over 2 years, I noticed it had gotten a little bit bigger in size. It wasn't rapidly growing. This was the clinical appearance and the dermoscopy. So I decided I was going to follow it for 3 months and see what happens. This was what happened over 3 months. This is both non-polarized. You can see it's gotten slightly bigger. The vessels are more pronounced. So we'll zoom in on that. You have a dotted vascular pattern. So the differential diagnosis of this, Spitz, right? This is an elderly woman in her 60s or 50s, I believe. That's not a typical age for a Spitz nevus. Really, you have to rule out amelanotic melanoma in this particular example. The pathologist had a difficult time with this, but they felt that it was most in keeping with malignant melanoma, 0.25 millimeters. So now I will have the audience participate. So for each of the next 4 cases, there's going to be 1 lesion on the left, A, and 1 lesion on the right, B. And I'll just have you guys hold up your hands at the final part in terms of what you think the diagnosis is. I'm only going to ask you, do you think it's melanoma? Yes or no? So here's an older female with a pink lesion on her leg. And we have an adolescent female with a pink lesion on her leg. This is the clinical appearance. So we'll start with the older female. All right, we see a dotted vascular pattern. And here's the young female. Again, we see a dotted vascular pattern. So who thinks A is melanoma? Raise their hand. Okay, you can lower the hand. Who thinks B is melanoma? So many more people thought A is melanoma. Why is that the case? They look identical in terms of the morphology. The only way was based on age, right? So you guys were correct. But what you used was age, not morphology, to help you reach that diagnosis, okay? So So it raises an important point that amelanotic melanomas often simulate Spitz lesions. Age can be useful, but in my practice I tend to remove anything that looks Spitzoid in appearance outside of a very young individual. And this is highlighted very nicely in this paper from Emilio Lalas, I think in 2015. They looked at the likelihood of finding melanoma when removing a Spitzoid-looking lesion in patients 12 years or older. The main message is that the overall probability was about 13%, and that these symmetric lesions that look like Spitzoid lesions would be melanoma. The older the age of the patient, the probability increases. So if you're over the age of 50, the probability is about 50%. And here are some examples from that particular publication. Not all of them are amelanotic. The Spitz nevus is always on the left, the melanoma on the right. You can see these essentially have identical morphology, identical morphology, identical morphology. So in my practice, I remove these lesions, and morphology alone is not able to separate this out. All right, second example. So we have lesions on the legs, right? So A, lesion on the leg, B, lesion on the leg. We'll look at A to start with. Here's the dermoscopic appearance. We see mostly dotted vascular pattern. B, much more scaly in appearance. We do see dots, but if you zoom in a little bit more closely, the dots are a little bit more glomeruloid in appearance. So, on the left we have an example of invasive melanoma, on the right we have an example of squamous cell carcinoma. So sometimes there can be some overlap between these lesions. The clues for squamous cell carcinoma, more scale than in the melanoma, and the vessels will appear more like glomerular vessels and not so much as tiny dots. Alright, this is a tough one. So, pink lesions on the arm of a lady, two different ladies. They're about the same size, and clinically they appear quite similar. So we'll look at the dermoscopic for A and B. So here's A. This is the dermoscopic appearance. We'll zoom in. And B. The dermoscopic appearance. We'll zoom in. So I'll tell you, one of these is basal cell carcinoma, one of these is melanoma. So now we'll vote. Who thinks A is melanoma? Who thinks B is melanoma? So you guys got this right, B is melanoma. So you can see how powerful just the basis of vessels here is in terms of helping you reach which one is more likely to be melanoma. Now you would have biopsied both of these anyway, right? So this is just confidence in exactly what the diagnosis is. But it should remind you, you should not treat these lesions as a presumptive diagnosis of something without histologic confirmation. So the left was basal cell carcinoma, the right was melanoma. And here's my last example. So lesion on the leg of an individual, very small pink lesion, about 2 to 3 millimeters in size. Another small pink lesion, 2 to 3 millimeters in size on the back. Got the dermoscopy. Zoom in. So who thinks A is melanoma? Who thinks B is melanoma? Who thinks A is melanoma? So A is the melanoma, right? You have the dotted and irregular vessels here. B, you don't see any vessels, right? You see a pink lesion, okay? B is lichenoid keratosis. I thought that was going to be basal cell carcinoma. A is melanoma, invasive, 0.3 millimeters. So the other differential diagnosis is lichenoid keratosis. And sometimes it can be impossible to distinguish. This is an example where it's particularly, I think, useful in the dermoscopic appearance. But amelanotic lichenoid keratoses can simulate melanomas as well. So in terms of amelanotic melanoma dermoscopy, in my experience, the two most powerful presentations that are useful in